now we are following with the second speaker, my colleague Pablo from Consorcio Hospital General Universitario.
Okay, thanks for the presentation. I'm going to talk about the role of regional anesthesia in postoperative pain management after MITS. Ana Broseta has made a magnificent presentation on fascial blocks in video-assisted and robotic thoracic surgery, and it is inevitable to repeat some series of concepts and references. But we will take advantage of the situations to reinforce the most important aspects of regional anesthesia in these surgeries. So let's start by following this structure. We will mention the importance of postoperative analgesia and describe the main techniques that we can perform to control pain in postoperative period. Then we will see another type of pain that can occur in our patients, ipsilateral shoulder pain, and what blocks have been described as treatment. And finally, we will talk about the importance of optimal analgesia in the postoperative period to avoid chronic pain. And how important it is to maintain good pain relief in the postoperative period? Well, we are going to see that this determines a series of very relevant factors beyond the patient's comfort. Thoracic surgery causes significant postoperative pain, and an effective analgesic strategy in the perioperative period is essential to avoid postoperative complications, such as hypoxemia, hypercapnia, or pneumonia, and enough recovery. Poorly controlled acute pain may also increase the risk of chronic post-thoracic surgery pain syndrome. The approach in thoracic surgery has been changing over the years. Thoracoscopy approaches involve smaller incisions and the use of trocars for video and instrument access to the chest cavity, and oftentimes mini thoracotomies for access and specimen removal. These minimally invasive techniques confer less disruption of the chest wall muscles, potentially less damage to intercostal nerves, and are associated with decreased postoperative pain, opioid consumption, and reduced incidence of postoperative complications. This has generated a change in gold standard of regional analgesia. While in thoracotomy, the technique of choice was continuous epidural or paravertebral infusion, in videothoracoscopy and robotic surgeries, regional anesthesia was debated between paravertebral and fascial blocks. However, despite the reduction in damage and pain, some studies show that postoperative pain remains moderate or find no difference at all compared to other approaches. Therefore, postoperative pain in minimally invasive thoracic surgery continues to be relevant and represents a challenge for the anesthesiologist. Accordingly, it is essential to know the role of regional and fascial blocks to maintain effective analgesia in the postoperative period of these surgeries. So we are going to continue the order of this session by describing the most relevant regional and fascial blocks. Since the previous presentation has already focused on the intraoperative management of regional anesthesia, our focus will be on the blocks that we can perform as analgesic rescue in the postoperative period. We will find the situation when a patient presents moderate or severe pain in the postoperative period due to failure of regional anesthesia, exclusive management with systemic analgesia, or insufficient analgesia or loss of effect of the intraoperative block. We are going to complete this table with the main characteristics of each analgesic block. The thoracic paravertebral block has been described with the patient in the sitting, lateral, or prone position. Both parasagittal and transverse approaches has been described. Local anesthetic spreads in the paravertebral space into multiple levels, and it provides somatic and visceral analgesia. Complications are rare. The main ones are pneumothorax, dural puncture, epidural hematoma, and hemodynamic alterations. Thus, the main features are somatic and visceral analgesia, single puncture, and the most frequent complications, such as pneumothorax, dural puncture, epidural hematoma, and hemodynamic alterations. The intercostal nerve block is performed by depositing the local anesthetic under each rib. It is an easy technique to perform, but requires multiple shots. Complications such as pneumothorax are rare. However, the rapid and high absorption of the area can cause local anesthetic toxicity. So the main features are only somatic analgesia, multiple punctures, and the most frequent complications such as pneumothorax and local anesthetic toxicity.